Welcome to the virtual panel discussion on digital tomosynthesis in orthopedics. The goal of the session today is to talk about the benefits of using digital tomosynthesis in practice. My name is John Carrino. I work as a radiologist and the Vice Chairman of Radiology at the Hospital for Special Surgery. My specialization and interest includes all of musculoskeletal imaging, orthopedics, rheumatology, and bone health. I perform diagnostic radiology and image-guided procedures using a variety of modalities. I did my medical school training at George Washington University, received a master's in public health at the Harvard School of Public Health, radiology residency training at Yale New Haven Hospital, and have been fortunate enough to have been listed on a number of top doctors lists. And my affiliations include working as a Spine Intervention Society instructor, being the radiology co-director for North American Spine Society, and working with the DICOM Standards Committee.
My name is David Quinn. I'm from Albany, New York. I'm an orthopedic surgeon. I'm a hand surgeon in private practice, working in conjunction with the Division of Orthopedic Surgery at Albany Medical Center. My bona fides are as you see on the slide. Back to you.
My name is Samir Mehta. I'm an orthopedic trauma surgeon at the University of Pennsylvania. I'm also chief of the trauma service here at the University of Pennsylvania. I have a lot of interests in complex orthopedic trauma, including pelvic and acetabular fractures as well as periarticular or fractures around the joint. I did my fellowship training at the University of Washington Harborview Medical Center, and I'm affiliated with a variety of different organizations. But again, my principal interest is in clinical care and education.
Hello, I'm John Sabol. I'm Chief Scientist within the Research Division at GE Healthcare. I've got about 25 years experience in developing advanced applications for X-ray imaging, in particular applications like tomosynthesis and dual energy. Trained as a medical physicist at the University of Toronto and currently working at GE Healthcare. Dr. Carrino?
Thank you, John. So we'll start off talking about terms and terminology. So digital tomosynthesis, or DTS, is a computer-generated images consisting of multiple contiguous slices of a variable radiodense object. VolumeRAD is the GE version of digital tomosynthesis. So let's start by talking about the benefits of digital tomosynthesis. Dr. Quinn, I'd like to hear from you and how you're using GE's VolumeRAD digital tomosynthesis technology today and what benefits you're seeing in your practice.
Thank you, Dr. Carrino. I think the answer to that question requires some context. I consider myself a typical orthopedic surgeon in an atypical practice here in Albany, New York, where we work out of this building that does just musculoskeletal care. But we have a lot of hats, despite the fact that we're primarily in private practice. We're trying to take good care of patients. We're trying to mitigate risk. We're trying to support the academic mission of Albany Medical Center, which has outsourced the management of their division to our group. We're trying to maintain a healthy economic situation to the degree we can, and digital tomosynthesis helps us along all those axes. And I think the cases will help illustrate that. I happen to be an early adopter of the modality and have found over time roughly 5% of the patients I see in the half time that I'm in the office week to week benefit from this additional imaging. And again, the cases will illustrate that. Chiefly, next slide maybe. Here's just a very short slide indicating the scale of our practice. But the important number there is about half of the patient visits per year include plain X-ray studies. And of the plain X-ray studies, in my share of those plain X-ray studies, about 5% of them are supplemented with digital tomosynthesis. Fundamentally, as orthopedic surgeons, we're trying to answer some very simple questions, especially with respect to fracture care. But before we've even decided that a fracture is the problem, we ask this, whether we're aware of it or not, this very simple series of questions. Is there a problem? Does the patient need an operation, or is it indicated? Has it been done properly? Is the problem resolved? And I found that digital tomosynthesis helps answer these questions in a substantial percentage of cases with minimal risk and minimal expense. So what we don't like, as most people don't like change, we don't like shades of gray, we don't like inaction, uncertainty, and expense. And I found this modality can help us across the board here. So with respect to fracture care, digital tomosynthesis helps me answer the question, is there a fracture? Is it displaced? Is it intraarticular? How displaced is it? If intraarticular, with either closed or open reduction, has the joint surface been restored, and has the fracture gone on to heal? And again, I think the cases will illustrate some of these points. Dr. Carrino, so I have 3 upper extremity cases that each show different aspects of the natural history of fractures before, during, and after, or past, present, future, maybe we would call it. But this first case asks the question, is there a clavicle fracture? This was an adolescent female, maybe 16, who'd fallen off a horse and had shoulder girdle pain localized largely to her medial clavicle. She was active in sports. She wanted to get back on the horse. She presented to an ER. She presented to another orthopedic surgeon, and she had some swelling and tenderness over her medial clavicle, but her plain radiographs, if you can at least take my word for it, in a couple of instances, were normal. But because she was always at risk of falling off the horse again, we didn't want to send her back before we knew if there was a fracture and if it had sufficient time it had elapsed for it to have healed. So this is the original study, and then we'll take a moment and look at the digital tomosynthesis series. And then in the next slide, we take a screen grab of one of the series of the study, similar to taking a single cell out of a movie or out of a cartoon movie. And there we see over the very inferior medial aspect of the clavicle is a non-displaced fracture, which was precisely where she'd been tender. So knowing this, we were able to A, reassure the patient and her family that this was a problem, and B, put together a timeline for her return to full activity. This next case involved a 20-ish year old patient who had fallen on pardon me, the outstretched extremity and sustained this intraarticular distal radius fracture at the junction of the scaphoid fossa and the lunate fossa that was arguably stepped off, given this patient's age and activity, to a sufficient degree to indicate restoration more anatomically of the joint surface. And so we get a sense of that on the plain film, but by obtaining a digital tomosynthesis study, which we'll look at right now, we could come to a conclusion. Looking at the screen grab from the study on the left, that best showed the step off of about 2.5 to 3 millimeters. We elected to go ahead and fix this and restore the more normal anatomy, start them moving, etc. So it gave us the information that I suspected was there, but couldn't say with sufficient certainty was there to go ahead and recommend surgical treatment. And then the last case we have was this is to determine whether or not the scaphoid fracture had healed. This young man had fallen on his outstretched extremity, sustained a completely non-displaced scaphoid fracture, been treated non-operatively, and in follow-up, some 6 or 7 weeks later, really wanted to get back to his contact sport, but had a trace amount of tenderness in the snuff box. We see on the plain film that it looks like his fracture is healed, but there's a question of the ulnar half of it, or perhaps more, at least enough so that I ordered a digital tomosynthesis study to have a closer look at the healing pattern. So the next movie we'll see is a series of images that demonstrate that study. So again, taking out the most informative slice of that study, we can see quite clearly still a moderate portion of the ulnar side of that fracture is not completely healed and put together with his tenderness allowed me to come to the conclusion to keep him out of his sport for a further time period. So those are the three illustrative cases that I thought might show the various ways that one can leverage this technology, this modality, in my daily practice. Back to you, Dr. Carrino.
Great. Thank you, Dr. Quinn, for sharing on how you're using digital tomosynthesis in your practice today. So now we'll turn to Dr. Mehta. Dr. Mehta, we're going to ask how you're using GE VolumeRAD digital tomosynthesis and what your benefits you're seeing in your practice.
Thanks for having me. I'm very excited to talk about this technology. It is a novel technology, and I think for us at Penn, at least in our division of orthopedic trauma, the real question is, where does it fit in? You know, anytime we talk about new technology, there's always questions about cost and, you know, workflow and do I really need it? And, you know, we kind of get stuck in our ways. We kind of come up with patterns and formulas and algorithms that seem to work. And so where does it fit into my practice? And then should I be the first to adopt it? You know, we just heard a great talk about early adoption and how it could be utilized, but do I really need it? You know, and let somebody else figure out the nuts and bolts of it, and then, you know, hand it off to me. And then the other aspects of any time you talk about novel or new technology, and I would argue this isn't new. It's new to orthopedics. It's new to me, but it doesn't seem it's not that new in terms of other subspecialties that have been using it. But where's the value? How do you convince a patient to go get a tomo as opposed to some other imaging modality, and why is it important for you as the practitioner and the patient as a recipient? And then the last sort of thing is, as sometimes we do in academics, is that this is really an academic discussion, or is this for real? You know, what I mean by that is this is great to talk about at conferences and show fancy images in fracture forums or in different meetings at the podium, but really, is there some aspect to this that really has some significant clinical benefit, or is this some great technology that we can put in manuscripts and talk about but never really use, or better yet, can only be used at certain places with certain machines, and, you know, not everybody can use it, and, you know, interpretation's hard. And so all these things I think are really important when we talk about adopting and looking at new imaging technology. You know, I'm going to use ultrasound as an example. I think ultrasound's a great tool. I have no idea what I'm looking at when I look at ultrasound images other than a big snowstorm. And I'm very, very dependent on some of my colleagues in musculoskeletal radiology to perform the test and then to interpret the test. And then when I sit with a patient, I'm a very visual person. It's hard for me to look at that and be able to really make any sense of it and then try and explain that to the patient in that clinical setting. So I think that's also another aspect to this when we talk about the reality of it. So as we move forward with this presentation and we look at what we do in our practice, I'm at a level 1 trauma center. It's an urban center. We are guilty of, I think, what a lot of trauma centers are guilty of, which is exposing everybody to radiation and CTing everything. I think that's sort of become the standard, if you will. You have an injury, you come through the trauma bay or the emergency room, and before you even get plain films, you're going and getting pan scanned. And pan scanning, I think, has become a rite of passage if you're coming through a trauma center. In addition, I think what's important to remember is you get pan scanned, and then, oh wait, there might be an acetabular fracture there, and I want fine-cut images of that acetabular fracture so I can preoperatively plan. So let's go back in the scanner and let's get some 1 millimeter cuts of that acetabulum. Or the ankle was dislocated, or there was a bad pilon fracture, or there was a bad tibial plateau fracture. We're going to take that patient to the operating room. We're going to put them into a external fixator, and we're going to get a new CT scan with the ligamentotaxis in effect, so you can really get a better idea of what the joint looks like. And we all are readily aware right now of the dangers of radiation exposure and how much. And our patients are talking about it. We're talking about it in our orthopedic society meetings. We're talking about it at the OTA and at our AO meetings. We're teaching the residents about it, yet we're not practicing what we preach when it comes to trying to limit radiation exposure. And then you tack on fluoroscopy in the operating room, intra-op CT, and post-op CTs. And so it really starts to add up very quickly. And so I think one big benefit of this technology is the potential for decreasing radiation dosage by a lot. And I'll show you some examples of that as we go through some of our cases. I think in my practice, we're doing it for a variety of reasons in the orthopedic trauma world. We're looking at hardware positioning. So we do some complex reconstructions with acetabulum and pelvic rings. We're doing things more and more percutaneously with fluoroscopy, small incisions, smaller wounds. And so we're doing things a little bit blind. And I say blind, but not really. We're using imaging to help us. But it's hard to take a three-dimensional object and look at it in 2 dimensions and try and place hardware, a 7 millimeter screw in an 8 millimeter tunnel. And so oftentimes we'll get a post-op CT to address the safety of our hardware. Is our hardware really where we want it to be? Is it violating the articular surface? Is it not in the isthmus of the canal? And so we get this CT just to make sure we did it okay. We're taking, as I mentioned before, a complex 3-dimensional anatomy. We're dialing it down to 2 dimensions, working on that using traditional fluoroscopy in the operating room, and then trying to then understand this complex 3D anatomy either preoperatively or postoperatively. And we saw some great cases already of articular fractures, which on a 2D image, a plain film radiograph, AP and lateral, you can make it out, it's there, but to really understand that fracture in multiple planes, you need to be able to see it in multiple planes, and that's going to dictate potentially whether it needs surgery, the kind of reduction that it needs, and where you're going to place your hardware. And all of that really, there's plenty of data now to show that 3-dimensional understanding of fractures really makes a big difference in the way you treat them. I think the other thing that we get and we need is out-of-plane imaging. These fractures don't really follow a rule of thumb. Unfortunately, the textbooks, the patients and the way they injure themselves don't read textbooks. Sometimes they do. That's just weird. But in general, most patients don't read textbook, especially when they get on their motorcycle and drive it into a tree or a wall. And so their fracture patterns don't always follow the same route or the same pattern, and as such, what we can get with advanced imaging is an ability to understand our fracture pattern when it's out of plane, and VolumeRAD really does this very well, and you'll see some great examples of this. In addition, things like non-unions or periarticular injuries, which are very challenging sometimes to diagnose because there's existing hardware there, and a CT scan just gets very cumbersome with all the existing hardware. You'll see an example, actually all of my examples involve existing hardware and being able to see around that hardware or with that hardware in place without a tremendous amount of scatter. The other thing that we're doing in our practice is we're really aggressively gathering data. We're looking at this, again, from an academic perspective, as academicians do sometimes, and we're trying to really understand who and when and where and how much radiation and cost and time, and looking at these things prospectively in an effort to really gain an understanding of how this can be utilized. The other aspect of it I think that's really important is the education. You're educating our orthopedic residents and our fellows and our advanced practice providers, our nurse practitioners and our PAs who are ordering these exams so that we don't have to necessarily send patients back or not get a CT unnecessarily, but rather get a VolumeRAD image, which will give us potentially similar information. In addition, I always like to remind people that it's not just us. When I say us, I'm talking about the orthopedic surgeon, since I'm so specialty centric, but also the other people that are involved in the practice and care of our injured patients, like ER physicians, family medicine docs, trauma surgeons, general trauma surgeons, all of whom participate in the care of our patients who might get these imaging studies before they even contact us. And I think that's an important part of, as you start to utilize this in your practices, remember there's lots of other people who could be helping facilitate getting the information that VolumeRAD can provide before the patient ever comes to your door. I think ultimately what VolumeRAD really does, and digital tomosynthesis does, is it takes an uncertain situation and provides some certainty to it. It provides you additional information that could be utilized in helping make care decisions, and we've seen already some fantastic examples of that, and I hope to show you a few more in a few minutes. And as we talk about this, as we move forward, I think one of the important concepts, and you'll see this on my next slide, and I think the imaging really kind of says a lot as we move forward, is we really want to break the chain. Unfortunately, one of the things we do is we get into these patterns. I sort of described this earlier. We get into this pattern of patient comes in, they've got an articular injury, we're going to get a CAT scan, we're going to do X, Y, Z, and I think part of it is let's redefine the algorithm a little bit. Let's help facilitate. Let's not automatically get that CT when a patient has a non-union. Let's not automatically order that post-op CT on the pelvic and acetabular patient. Let's not automatically get a CT on that trimalleolar ankle fracture. There may be other imaging modalities that can provide just as much information that could be utilized by the practitioners and not expose the patient to as much radiation, and do it in a way that makes sense. And so breaking the chain of how we traditionally do things, I think, is really going to be important as we move forward with this. And as you see some of these examples, you're going to say, wow, I wish we never got that CT. We could have just started off and gotten that VolumeRAD image, and we'd be at the same point we are now, potentially. So I think some of this is, as we move forward, I think some of this is really about decision making. And as we think about these images, instead of just doing a visceral reaction to or a guttural reaction to I have to get a CAT scan, really consider what you're looking at, and can you utilize VolumeRAD to get the same information or potentially even more information, and you'll see this shortly in some of the imaging studies I'll show. Can we affect the decision making of what we do? Because ultimately that's what we're talking about, right? We're talking about, and we heard this before, how to make decisions. You know, in my mind, every time I see an injured patient, you know, the algorithm is very simple. I'm not very smart. It's binary in some ways because it's easy to make binary decisions. Is this an operative injury or is it non-operative? If it's operative, what's my pathway? What am I looking at? What am I trying to do? If it's non-operative, am I sure it's non-operative? And if it is non-operative, how do I assess my progress and assess my potential either maintenance of reduction or loss of reduction, so we're not going back into the operative algorithm? And it's all about decision making, and now in this day and age, shared decision making with your patient. So having these images to show them, I think, is really important. I'd like to highlight VolumeRAD and with a couple of really, I think, unique cases. Unique in the sense that you can see as we move forward through this presentation, you can see how there's a direct benefit potentially of VolumeRAD. So here's a case that demonstrates the utility of VolumeRAD. So this is a 89-year-old female. She had a previous hip replacement that's old. She had a fall at an outside hospital or outside facility. She's an independent ambulator in the assisted care living facility that she's at, and she broke her pelvis. Interestingly, she had an anterior ring injury that was seen on X-ray, but no CT was obtained. She was followed up in an orthopedic surgeon's office 2 weeks later. They got an X-ray. The anterior ring was starting to displace, and they transferred her to us. Because she was an independent ambulator that wasn't able to ambulate and having significant pain, we went ahead and we fixed her pelvis with a screw in the back and a screw in the front. You can see those are the purple objects that are not the hip replacement that are on this post-op CT. The reason we obtain a post-op CT is these screws are placed percutaneously, and we want to make sure that they're safe, that they're not in the joint. In this case, it doesn't matter, but they're not also in the sacral tunnels affecting nerve roots, because everything we do is essentially off fluoro in the operating room and it's somewhat blind. and it's been our protocol to get post-op CTs. Well, if you look at this rendered image, so we've already gotten the axial, coronal, and sagittal cut, so we've exposed the patient to all this radiation. We get this rendered image to see where our imaging, our implants are at, and you can see in this rendered or ghost image that you can't really tell what's going on with the screws. Are they in the right place? Do they go in, out, in? Are they contained? And it doesn't really help us very much. If we go forward to the VRT image, so this is another rendered image off of the CT that we're going to see very shortly, you can't really see anything in this. The hip arthroplasty hardware takes up there's so much noise around it. I can't even see my screws in the bone, which I guess means they're safe, but I don't really know because I can't really see where they're going inside the bone. I can't see what's going on in the back of the pelvis at all. While this is a great fancy 3D image to look at, it gives me absolutely no information in terms of what I'm looking at. The interesting thing is when you go to the VolumeRAD, which is our next image, and you play the movie, and you'll see this movie as it's playing. I'm going to keep talking through it a little bit. As you watch the movie of the pelvis going through on VolumeRAD with the digital tomo, you can now see where the screw is. You can tell that it's in the canal. This is the anterior screw we're looking at. You can do the same thing for the posterior screw. And I can get as much, if not more, information from this VolumeRAD for this case as I could with the CT without obtaining nearly as many images, without the rendering of those ghost images or the VRT images. And this movie really shows that that screw is safe. It's in the tunnel. It's right where we want it to be. And the hardware is essentially appropriate for its location. So a very good example of what we want to do with this series of images. We'll go on to the next presentation or the next patient, and this is another interesting or unique patient. This is a 58-year-old physician who has had thigh pain, and I'm going to zoom out in a second to kind of give you a bigger perspective of his fracture. But here's his sort of large perspective of his fracture. He had a hip replacement. He then had a femur fracture below his hip replacement. He was then fixed with plates and screws. That didn't work out so well for him. He got then fixed with a rod, and then he was ultimately referred to me with this x-ray, and it looks pretty good. I mean, you can see the tip of his hip replacement. You can see the rod going up his femur. And if you zoom in on the fracture, you can see, I think the fracture is healed. I look at this and I'm like, man, that looks pretty good. I don't understand why you're having thigh pain. Maybe it's just that you've had multiple surgeries. This guy is active. Maybe he's just trying to push too hard. I don't really know, but this looks pretty good. It looks healed. I mean, I would look at this APN lateral and without a doubt tell you this fracture is healed, with the exception that his clinical story isn't making sense. And again, when you get that step back perspective a little bit, it really looks like he's healed. Having said that, it's clear that he's not healed when you look at the tomo picture here. The tomo picture will tell you pretty clearly that as we move through this movie, that he's not healing, and he's not healed at all. Actually, as you see the fracture line very, very distinctly on the lateral tomo image, and this is where, while you could get a CT scan, and we did, there's a lot of noise from that CT, and it's really hard to tell. But the tomo makes it perfectly clear that this patient needs an additional surgery to get him to union. And so these are just two real sort of interesting, complex sort of case examples of how the technology can really work in your practice. And so, again, I think if you're going to start to adopt this, I would encourage you to figure out where it fits into your algorithm and break the chain so that you can help have this have an impactful part of your decision-making process in the care of your patients. Thanks.
Thank you, Dr. Mehta. So now we're going to turn our attention to some of the physics behind this. And with Dr. John Sabol, we're going to look at the questions, what is digital tomosynthesis? How does it work? And how can it help in orthopedics? Dr. Sabol?
Thank you, Dr. Carrino. So I'd like to just talk a bit about what is digital tomosynthesis, VolumeRAD being the GE implementation of this technology. In many ways, digital tomosynthesis can be thought of as a digital version of the old plain film tomography, with one significant change, and that being with a single sweep of the X-ray source, we can acquire multiple slices. In fact, all of the slices through the entire patient. And in this way, it's more similar to computed tomography. And as we've seen in the clinical example so far, it helps by removing the overlying structure and giving the clinicians a way to see past the superposition of high contrast structures and be able to make a better diagnosis. The GE implementation of VolumeRAD takes up to 60 low-dose acquisitions during a sweep of the X-ray source. These acquisitions are essentially traditional plain X-ray acquisitions, but at an extremely low dose. The data from these acquisitions is then reconstructed using an algorithm very similar to what is used today in computed tomography to reconstruct a set of tomographic images, each image parallel to the detector plane. These DICOM images can be viewed on any PACS or review workstation. An interesting feature is that the acquisition sweeps can be performed either at the wall stand or on the table. And this gives tremendous flexibility in terms of the types and number of exams that can be acquired. So here we see some videos of the different acquisitions, be they at the wall stand with the patient standing. An interesting one is cross table at the wall stand. So here the patient is wheeled in on a gurney, the sweep occurs, and we can do, in this case, in this example, a cross table C-spine exam. And of course, the tomosynthesis also can be done with the patient lying on the table. With an extended arm wall stand, the patient can be rolled up to the wall stand on a gurney, and an acquisition can be done using the wall stand essentially as a table. So with this flexibility of the system, you can acquire virtually any traditional view that you would get with a standard radiograph. And with the software provided, over 30 different views are supported. And this lets you do virtually all of the exams that you would do with a traditional radiograph you can acquire in this volumetric mode as well. Interesting feature with the tomosynthesis is that it really is just a software upgrade to what is a regular X-ray rad rim. And so with minimal effort, minimal cost, and virtually no change to the workflow, you can add volumetric imaging to your standard of patient care. Dr. Quinn showed a number of examples of wrist applications of tomosynthesis, and Dr. Mehta pointed out the implications for increased radiation dose by the increased frequency of ordering advanced imaging like CT. So for those reasons, I've highlighted this particular paper by Drs. Noel and Bloom on dosimetry of wrist imaging with tomosynthesis. Dosimetry of tomosynthesis is a challenging topic for a number of reasons, one of which is just the standard of what you compare tomosynthesis dose to. Is it a single tomosynthesis exam compared to a radiographic exam, or is it a complete series of images versus, say, what you would acquire with advanced imaging like CT? In this study by Drs. Noel and Bloom et al., they looked at a 5-view wrist exam, standard protocol at their institution, with conventional radiography, versus a 2-view VolumeRAD exam, just a PA and a lateral. And they found that the VolumeRAD exam has utilized 25% less dose, 0.72 milligray versus almost 1 milligray with the conventional imaging. So in this sense, despite the fact that you're taking up to 60 multiple images in the single tomosynthesis acquisition, the end result is less dose to the patient than even conventional X-ray. If we compare this to computed tomography, it's over 28 times less dose than an equivalent CT exam. So for further information, I'd recommend that you visit the GE Healthcare webpage. On that page, there's additional case studies than would have been presented today, webinars, bibliography of peer-reviewed published literature on many different applications of tomosynthesis, both musculoskeletal, orthopedic, and really applications across the entire patient. Back to you, Dr. Carrino.
Great. Thank you very much, Dr. Sabol. So now let's address some questions with the panel. For Dr. Mehta, how is it different to read a VolumeRAD image versus a standard radiograph? I know you touched upon this a little bit, but maybe you can expound a little bit more.
Thanks. I think that's a really great question because I think people worry about being able to interpret these images. Just like in residency and fellowship and in practice, I'll wander over to the MSK radiology room to review an MRI or go over an MRI. I've found that over time you start to learn some of the imaging, some of the signs, and some of the things, at least for basic things. And with ultrasound, I mentioned it earlier. I can't. I don't have the bandwidth to understand what I'm looking at. And so one of the concerns is when you start to introduce a new technology, a new imaging technology, where is it going to fall in that spectrum? The beauty of VolumeRAD is it's really like looking at an X-ray. It's just multiple X-rays stacked on top of each other, and I think that's the part that you have to get used to. What I've described to patients as to why we're getting it, or I've described to my residents, who will often look at it over my shoulder, who universally think it's very, very cool, by the way, is we're looking at a hologram. We're looking at this image that you can go back and forth in like slices of cheese, or bending one of those holograms you used to get out of Cracker Jack boxes, and you can see different things depending on how you bend it or which layer you're in. And that does take some getting used to. The interesting thing is that you have to reaccommodate and realize that you're not going to see a lot of noise or artifact from the metal if you're not in the layer of the metal, and you can get more bony detail. And the other thing that surprises me about it is the level of detail that I'm seeing. And when I go back to standard radiographs, I'm like, oh God, these are blurry. I mean, they're not blurry, but you're not seeing that that level of quality of detail depending on what layer you're in. So, but I would tell you that it's really not that different. You just have to scroll through the images, and once you've seen a few, it sort of comes, and it's actually easier than looking at a CT, because the CT is an axial or coronal or sagittal cut, and you have to kind of reorient those different images together to kind of create that image in your mind of what you're looking at. The VolumeRAD is an X-ray. I mean, it's basically an X-ray that you're looking at, and it's the layer of the X-ray that is really that makes the difference. So I think hopefully that answers your question.
Yes, thank you, Dr. Mehta. I think it highlights several important points that somebody who's evaluating the patient and making treatment decisions should be able to make observations on the imaging modality that they're comfortable with, and that reaffirms their decision making. So now I want to turn to another question and talk about the implementation process. Dr. Quinn, in your practice, you've implemented VolumeRAD. Can you talk about what that implementation has been like?
Yes, I can, actually. Before I do, I'd like to add just a word to Dr. Mehta's answer about getting used to looking at these studies. I think this is a good example, to my mind, the only example where technology is more easily adapted by the older person, in this case, older orthopedic surgeon. Throughout the 80s and the first half of the 1990s, we used standard plane tomography all the time. And so I'm quite comfortable looking at tomographic images, and have been since the day I first saw VolumeRAD. I'd say those of us over 55 might be having less trouble than those under 40. But let's address your question about talking about the implementation process. It's actually quite simple. As you said, it's a software upgrade. I think, frankly, it's in the machine already, and somebody pushes a button or turns a key, and there you go. The 656 has this functionality. In terms of our X-ray techs, they picked it up quite readily. I think most of the work is in the managing the images and deciding which of those series of images to include in the package that they're sending over to the PACS. it probably doubles their time. In terms of workflow, the average plain film study in our practice is about 6 minutes, and this study is somewhere in the 11 to 15-minute range probably. Implementation is simple. Dr. Carrino?
Thank you, Dr. Quinn. Now, a little bit of a follow-up on that theme. Once you have the implementation in your practice, you've done it as a point-of-care system, something that you can easily integrate into your current workflow or existing radiography rooms. How do you look at or measure the cost-effectiveness or return on investment for this type of technology?
Well, for me, this is really the critical question of this whole thing. When is it? What is the return on investment clinically, economically, in terms of society, in terms of time management? The returns on investment for this modality, in my mind, across all of these various axes is very high. It doesn't take much back of the napkin arithmetic to realize that even at very conservative rates of usage for a typical practice or individual, but really more likely a practice, at very conservative reimbursement rates, that the return on investment as to when one would get payoff, so to speak, the software upgrade, it's a very short period of time. But that's just a relatively small part of it. There are serious returns on investment for workflow within the office, and it's more than just saving the patient the time that it takes to go get a CT scan somewhere, and then to have to come back, and then there's another copay, and you're losing 3 days worth of time, or maybe a week and a half worth of time if you have to get prior approval for the CT scan, and the time that your staff spends trying to get that approval from an insurance company. VolumeRAD is here and now, and as I just said, takes 11 to 15 minutes to do, as opposed to a CT scan, which costs a factor of 10 more to A, buy the equipment to acquire the study, and B, some carrier to reimburse the study. But it's the entire flow of the patient through the office, and most of the patients in whom we use this modality get a plain film first, and then, as Dr. Mehta said, there's not you have a question in your mind. There's enough uncertainty that if we send the patient back for a very specific study. And what's interesting is when one looks at that study and it answers the question one was hoping it would answer, when one goes back to the plain film, yes, it's quote blurrier, as Dr. Mehta said, but in another sense, it's actually more obvious. So we're saving the doctor time, we're saving the patient time, we're getting to the diagnoses more quickly, more effectively. I would say about, and I'm just pulling numbers out of the air, probably digital tomosynthesis supplants well more than half of CT scans that I would otherwise consider. And then there's a larger issue that also has economics behind it, and that is the issue of this day of transitioning from fee-for-service to value-based reimbursement. That is, digital tomosynthesis will have as its strongest proponents, beyond those trying to minimize the radiation dose, especially in certain populations like ER patients and pediatric patients. But in those circumstances where one is trying to be most cost effective, whether it's a formal member of an accountable care organization, whether it's one is part of a bundled payment program, or whether one is just concerned about the federal government in its MIPS programs, or primary care doctors trying to decide which of their specialists are cost effective or cost wasting. All of these parties have an interest in how able you as an orthopedic surgeon are to get the most information for the least money, frankly. So I hope that answers your question.
Yes, thank you very much. I think you touch upon a few important points, one of which is regarding where one might decide to use the VolumeRAD vis-a-vis another modality. I know Dr. Mehta had mentioned this with CT, and I'm going to ask Dr. Mehta to comment a little bit more about when he decides to use VolumeRAD versus other imaging modalities.
So I think that that this question really ties into the previous two questions as well, talking about implementation and return on investment that Dr. Quinn has noted. I think, our implementation has been somewhat haphazard, for lack of a better word. We have a lot of residents, we have a lot of fellows, we have a lot of mid-level providers. We also have a wonderful musculoskeletal radiology department, but it's at a typical academic institution, and sometimes the left hand doesn't know what the right hand is doing. And what we have, though, is a champion on the MSK radiology side who really is helping push this along as well. And so there are technical issues. We have a EMR system that we're utilizing to order imaging, but there's no Tomo order in the EMR system, and so we have to hand write it in or type it in a free text box, but not all the techs look at the free text box. They look at X-ray and they don't see that it's a Tomo. I mean, these are things that are logistical but are very real issues, and so this has definitely affected our ability to implement it with the frequency that we would like to be using it, because the utility is pretty tremendous. And in the same vein, I think in terms of convincing, like our IT folks to add to find the time to add the Tomo line to the order set is one of those issues of there is a tremendous return on investment, and it goes into the idea that you just asked about an imaging modality like CT. When do we decide to use VolumeRAD? Right now it's hard to say that it's replaced CT for us, because CT is so ingrained in the culture of our institution and within our within our division, and again with other providers where the CT is already ordered. We get down in the ER to see the distal radius or the pilon or something, and the CT has already been obtained, and it's almost like we didn't need that. We could have done it without that, and so a lot of that is education. Right now we're using it in our clinics where we have a little bit more control, obviously, in things like in any issue really where we would traditionally get a CT. We actually have little signs up reminding us that don't forget about getting a Tomo, or don't not get a Tomo, and so. If, for instance, if I have a patient, with a non-union, I would historically get a CT. I actually get a Tomo first now. I can get the Tomo in my office. I can get the Tomo result back right away, and and if I'm still not sure what's going on, which is a rarity with Tomo, then I will send the patient off for a CT, and then, as Dr. Quinn noted, see him back a week or 10 or 15 days later, and now you've delayed their care by a couple of weeks when you could have had the answer. So for us, it's anywhere that we could get a CT, or we would be routinely getting a CT in the outpatient setting, we're now getting a Tomo instead, as long as we have the imaging protocol in place for it. So it's really become it's becoming more and more common for us to obtain that. Again, it's also an educational process. I get a new resident every 6 weeks. Invariably, I'm talking him or her out of getting a CT and getting the Tomo. So again, we're introducing this, and so it seems like sometimes we're reinventing the wheel every 6 weeks. But again, once they see the technology, it becomes easier to implement. And I suspect that as we get through a few more residents, it'll become almost second nature. So with that, I'm going to turn it back to you for more questions.
Thank you. Well, I think with that, we've covered a broad base of digital tomosynthesis. We've reviewed the physics. We've reviewed how one would use it in their practice, how one would implement it, and some of the economic and workflow implications. I want to thank everybody for participating in the sessions, and if there's more information that's required, you can obtain it online at the GE website. Thank you very much.